This documentary will help you understand the respiratory system and the drugs that keep it working. The respiratory system is one of the body's most essential life support systems. Every breath brings oxygen into the lungs and removes carbon dioxide from the blood, keeping every organ alive and functioning. In a single day, the lungs filter, warm and humidify thousands of liters of air, while only a small portion of total lung capacity is used at rest. When disease disrupts this delicate system, the consequences can range from mild discomfort to life-threatening illness. In this documentary, we will explore how the respiratory system works, the major categories of lung disease, and the medicines used to treat them. We will also look at how these diseases affect real people in everyday life, from the student with asthma who struggles during exercise to the older smoker with chronic obstructive pulmonary disease. By the end, the logic behind respiratory drug therapy will become much clearer. The lungs do far more than simply move air in and out. Their main job is to replenish oxygen in the blood and excrete carbon dioxide, the waste gas produced by metabolism. Air enters through the nose and mouth, passes through the airways, and reaches the alveoli, where oxygen and carbon dioxide are exchanged between the air and the blood. The airway system also prepares air for the body. It filters dust and particles, warms incoming air, and adds moisture before the air reaches the delicate lung tissue. This is why breathing problems can quickly become serious. If the airways narrow, fill with mucus, or become inflamed, the body is no longer able to exchange gases efficiently. In practical terms, a blocked or irritated airway is not just an inconvenience, it can directly threaten oxygen delivery to tissues. A real-life example is a person with severe asthma walking into a dusty room. Within minutes, inflammation and airway tightening may begin, making breathing difficult and triggering wheezing or chest tightness. This is one reason respiratory pharmacology is so important. The right medicine can reopen the airways and restore airflow. Respiratory diseases are pathological conditions that affect the structures responsible for gas exchange, including the trachea, bronchi, bronchioles, alveoli, pleura, and even the muscles and nerves involved in breathing. These diseases can be mild and self-limiting, such as the common cold, or severe and potentially fatal, such as pneumonia, tuberculosis, pulmonary embolism, lung cancer, COPD, and COVID-19. Pulmonology is the medical field that studies these conditions, and pulmonologists specialize in their diagnosis and treatment. A useful way to understand lung disease is by classification. Obstructive diseases involve narrowed airways and trapped air. Restrictive diseases involve stiff lungs and reduced expansion. Infectious and inflammatory diseases are caused by pathogens or immune-driven inflammation. Vascular diseases interfere with blood flow through the lungs. Lung cancer and occupational diseases such as pneumoconiosis represent additional major categories. This classification matters because it helps clinicians choose the right treatment. A patient with asthma needs airway-relaxing drugs and anti-inflammatory medicine, while a patient with pulmonary fibrosis may need a completely different approach. In other words, knowing the category of disease helps determine the mechanism of treatment. Obstructive lung diseases are characterized by airway obstruction, which limits the amount of air that can enter the alveoli. The problem is not that the lungs are too small, rather the airways are narrowed, inflamed, or filled with mucus, making it hard to breathe out fully. Asthma, COPD, chronic bronchitis, and bronchiectasis are key examples. Asthma is a chronic inflammatory disorder of the airways. It causes muscle tightening, mucus production, wheezing, cough, chest tightness, and shortness of breath. Many patients notice that symptoms worsen with allergens, exercise, cold air, or respiratory infections. A familiar example is a child who develops wheezing after running in sports class or after exposure to pollen. In such cases, rapid bronchodilator therapy can be life-saving. COPD is different. It is a progressive disease caused by long-term damage to the airways and lung tissue, often from cigarette smoke or chronic exposure to fumes. Unlike asthma, which often varies and may be reversible, COPD is usually persistent and progressively limiting. Many long-term smokers eventually describe a daily cough, excessive sputum, and shortness of breath even with simple tasks like climbing stairs. Bronchodilators, inhaled steroids in selected cases, and smoking cessation are central to management. Bronchiectasis is another obstructive condition in which the bronchi become widened and thickened due to inflammation and infection. This leads to mucus retention and repeated infections. Patients may have chronic productive cough and recurrent chest infections. The cycle is simple but harmful. Infection causes inflammation, inflammation damages the airway, and damaged airways trap more mucus, which invites further infection. Restrictive lung diseases are marked by reduced lung compliance, meaning the lungs are stiff and cannot expand normally. This produces incomplete lung expansion and a reduced lung volume. Causes may be intrinsic, such as tissue injury from inflammation or toxins, or extrinsic, such as neuromuscular problems or chest wall limitation. Pulmonary fibrosis is a classic example. In this condition, lung tissue becomes scarred and thickened, especially around the alveoli, making it difficult for oxygen to enter the bloodstream. Patients often complain of progressive shortness of breath, dry cough, and reduced exercise tolerance. Unlike obstructive disease, where air cannot move out easily, restrictive disease makes it difficult to expand the lungs in the first place. A useful everyday image is trying to inflate a stiff balloon. The problem is not that the balloon is blocked, it is that the material itself resists stretching. This is why restrictive disease often requires a different diagnostic and treatment strategy than asthma, or COPD. Respiratory infections can affect both the upper and lower respiratory tract. Upper respiratory tract infections include the common cold, sinusitis, pharyngitis, laryngitis, and tonsillitis. Lower respiratory infections include pneumonia, tuberculosis, COVID-19, severe viral syndromes, and fungal infections such as pneumocystis pneumonia. The common cold is usually a viral infection of the nose and throat, with symptoms such as sneezing, congestion, cough, and sore throat. Although it is often mild, it causes major discomfort and lost productivity worldwide. Sinusitis adds facial pressure and thick nasal discharge. Pharyngitis causes pain when swallowing, while laryngitis can lead to hoarseness or even temporary voice loss. Tonsillitis causes swelling and pain in the tonsils. Pneumonia is more serious because it affects the lungs themselves. It may be caused by bacteria, viruses, or fungi, and it can range from acute to chronic. A person with pneumonia may experience fever, cough, chest pain, and difficulty breathing. Community-acquired pneumonia can appear suddenly in an otherwise healthy person, while hospital-acquired pneumonia is often more complicated and resistant to treatment. Tuberculosis remains one of the most important chronic respiratory infections. Caused by Mycobacterium tuberculosis, it spreads through the air during coughing, sneezing, or spitting. In many parts of the world, TB still represents a major public health challenge. COVID-19, caused by SARS-CoV-2, reminded the world how quickly respiratory infections can spread and overwhelm health systems. These examples show why infection control, vaccination, and early treatment matter so much. Not all lung problems begin in the airways. Some begin in the blood vessels. Pulmonary embolism occurs when a blood clot travels to the lungs and blocks blood flow. Severe cases can cause sudden death. Pulmonary hypertension is elevated pressure in the pulmonary arteries and may strain the right side of the heart. Pulmonary edema occurs when fluid leaks into the alveoli, often due to heart failure. Environmental and occupational disease is another important category. Pneumoconiosis develops after inhaling mineral dust such as coal, silica, or asbestos. Asbestosis is an asbestos-related condition that causes scarring, inflammation, and breathing difficulty. These diseases are especially important because they are often preventable. A miner, factory worker, or construction worker exposed to dust over many years may develop irreversible lung damage later in life. To treat respiratory disease effectively, clinicians need good diagnostic tools. Chest X-rays and CT scans help visualize structural changes in the lungs. Pulmonary function tests, especially spirometry, measure how much air a person can inhale and exhale and how quickly they can do it. Bronchoscopy allows direct examination of the airways using a camera. These tools help distinguish obstructive from restrictive disease and guide treatment decisions. For example, a patient with asthma may show reversible airflow limitation on spirometry, while a patient with pulmonary fibrosis may show reduced lung expansion. Good diagnosis is the foundation of safe and rational drug therapy. Bronchodilators are medicines that relax the smooth muscles of the bronchi and widen the airways. They are among the most important drugs in respiratory medicine because they directly improve airflow. The main groups include beta-2 adrenergic agonists, anticholinergics, and methylxanthines. Short-acting beta-2 agonists, or SABAs, provide rapid relief of acute bronchospasm. Salbutamol, also called albuterol, is one of the most widely used examples. A real-life example is the asthma patient who keeps a rescue inhaler in a school bag, office drawer, or handbag for sudden wheezing. That inhaler can quickly reverse the tightening of the airways. Long-acting beta-2 agonists, or LABAs, provide longer-term control and are often used with inhaled corticosteroids. Examples include salmeterol, formoterol, and vilanterol. These are not usually used for immediate rescue. Their role is maintenance, especially in chronic asthma, or COPD. Anticholinergics block muscarinic receptors and reduce bronchodilation and mucus secretion. Ipratropium is a short-acting agent, while tiotropium is a long-acting agent commonly used in COPD. They are especially useful in chronic obstructive disease, where airway tone and mucus both contribute to symptoms. Methylxanthines, such as theophylline, also help open the airways. They have both bronchodilatory and anti-inflammatory effects. However, because of their side effects and narrow therapeutic range, they require careful use. In modern practice, they are less common than inhaled therapies but still clinically relevant. Inflammation is central to many respiratory diseases, especially asthma. That is why anti-inflammatory medicines are so important. Inhaled corticosteroids are the cornerstone of long-term asthma control because they directly reduce airway inflammation. Examples include beclomethasone, budesonide, fluticasone, mometasone, and cyclosinide. Systemic corticosteroids, such as prednisone, prednisolone, and methylprednisolone, are used for short-term management of severe flare-ups. These may be given during an asthma attack or a COPD exacerbation. Although powerful, they are generally not used casually because long-term systemic steroid exposure can produce many adverse effects. Leukotriene modifiers like montelukast block inflammatory mediators that contribute to bronchoconstriction and mucus production. They are useful in asthma and allergic rhinitis. For severe asthma, monoclonal antibodies can target specific inflammatory pathways. Omalizumab targets IgE, while mepolizumab, reslizumab, and dupilumab target other immune pathways. These treatments reflect the move toward precision medicine in respiratory care. Many respiratory diseases produce thick mucus, so clearing secretions becomes a major therapeutic goal. Expectorants help increase airway hydration, making mucus easier to cough up. Guaifenesin and ammonium chloride are examples. Mucolytics actually break chemical bonds in mucus, reducing its viscosity. N-acetylcysteine, carbocysteine, ambroxol, and bromhexine are examples. A practical example is someone with bronchitis who cannot clear sticky phlegm and coughs repeatedly at night. In such cases, mucolytics may help loosen the secretions so the patient can breathe and sleep more comfortably. These medicines are not dramatic in the way a rescue inhaler is, but for mucus-heavy conditions, they can be very helpful. Antitussives suppress the cough reflex. Opioid antitussives such as codeine may be used for severe non-productive cough, but caution is needed because of dependence and side effects. Non-opioid options such as dextromethorphan and benzonatate are also used. Respiratory drug therapy also covers allergy symptoms and upper airway congestion. Antihistamines reduce sneezing, runny nose, and itching. First-generation drugs such as diphenhydramine, chlorpheniramine, and promethazine can be sedating, while second-generation agents such as loratadine and cetirizine are generally less sedating. Decongestants, such as pseudoephedrine and phenylephrine, work by constricting blood vessels in the nasal passages, reducing congestion. Intranasal corticosteroids such as fluticasone, budesonide, and mometasone reduce nasal inflammation. These are especially useful in allergic rhinitis, where symptoms can be persistent and disruptive. A common example is the student who cannot concentrate because of nasal blockage, sneezing, and poor sleep during pollen season. In that situation, a combination of antihistamine and nasal steroid treatment may dramatically improve quality of life. This shows how respiratory pharmacology extends beyond the lungs to the whole upper airway. Respiratory medicine is ultimately about one thing: preserving the body's ability to breathe. Whether the problem is bronchospasm, inflammation, mucus, infection, fibrosis, a clot, or environmental damage, the treatment strategy begins with understanding the underlying mechanism. That is why respiratory drugs are organized into logical groups, based on what they do. From salbutamol in acute asthma, to budesonide in long-term control, from montelukast in allergic disease, to mucolytics in productive cough, each medication has a clear role. When used properly, these drugs can restore breathing, reduce suffering, and save lives. And in everyday clinical practice, that is the true power of pharmacology. I hope that was insightful. Thank you, and have a nice day.